Hey, Jim Hoffman here for EMS Office Hours. This is your Monday Minutes. This is going to be a short one, but I want to talk about the patient's neck, okay, and assessing that area when you're doing your initial patient assessment. When you think about assessing the patient's neck for a medical reason, JVD, or that jugular venous distension, is probably the one important thing you're looking for. Now, JVD happens when you get an increase in pressure that prevents the normal blood return to the heart from the head and neck. And this can occur as a result of overload of fluid, congestive heart failure, a pneumothorax, or even a tension pneumothorax, also pericardial tamponade or arrhythmias, things like bradycardia or AFib. So a lot of times we'll describe patients as having JVD when their necks are really fully engorged. I think it's important to remember that sometimes JVD can be a little more subtle, right? You don't necessarily see it as pronounced as this big engorged, JVD. So usually you need to assess it when the patient is sitting at a 45-degree Fowler's type position, and anything more than 3 centimeters or just slightly more than 1 inch of JVD ends up being considered abnormal. Okay, so the thing to remember though is that a patient who has significant JVD, while let's say if they're sitting upright or fully Fowler's, will have the same even if you lie them back. So repositioning a patient in that case really isn't needed, right? Because it's really significant distension. Okay, but if you're trying to assess JVD, you shouldn't really be laying the patient down in order to assess it. Okay. Some other things to think about, guys, real quick, because we're talking about the neck here. When you're looking at the neck, things that pertain to, let's say, a traumatic type injury, right? Things like subcutaneous air, tracheal deviation, or even things like looking at for a potential spinal injury, cervical spinal injury. So let's talk about subcutaneous air. This is the air that's just beneath the skin, and you can get that in the setting of penetrating a blunt trauma, okay? And this can be really a sign of significant airway injury and pneumothorax as well, okay? This subcutaneous emphysema can cause swelling of the tissue, and then when you sort of palpate that area, you might have heard it described as being like Rice Krispies or sounding like tissue paper, and you kind of feel the air is felt moving within the tissue. Okay. Now another thing you hear a lot about is that tracheal deviation. Right, it's a classic sign of the tension pneumo. All right. But a lot of times that importance of looking for tracheal deviation, things like that, okay, isn't necessarily true, because it's sort of a later sign of what's going on when you're looking for that, okay? But when you do have it, okay, the reason why you have a tracheal deviation is because you've got a large amount of that pressure on the side of that tension pneumo that's shifting the mediastinum towards the opposite side of the chest. So as a result, you get that tracheal deviation that's going to be away from the side of the thorax that's affected by that tension pneumo. Okay, so kind of a later sign, because you got to have that pressure building up. So look at other things that are going on with your patient to identify a tension pneumo, not just using that tracheal deviation as your diagnostic reason for saying the patient's got a tension pneumo. Now, one last thing I want to talk about is looking at the neck when you are talking about signs for a cervical spine injury, okay? You're thinking about maybe immobilizing the patient or maybe not immobilizing the patient, okay? Now we talk about significant. This is sort of that criteria when you talk about selective cervical spine immobilization nowadays, right? Where not every patient that has some sort of a fall or injury to the head or whatever necessarily need to have spinal immobilization, okay? So you're not trying to identify every patient with a neck injury, okay, to immobilize them, okay? But these criteria of selective spinal immobilization are really kind of meant to limit that use for immobilization for patients whom you might have a concern, for an injury to the cervical spine. Okay, so you don't want to compromise that spinal cord. Okay, so some things, in addition to you're looking for that spinal mobilization and neck injury, let's say the patient has trauma to the head or the neck or something like that, right? So things you should look at is altered mental status, low Glasgow scores, complaining of neck or spine pain, spinal tenderness. Maybe you can't assess the neck or spine, okay, because the patient has a distracting injury, okay, so you're not able to necessarily inspect the neck or the spine because of that, okay. Maybe there's already a spinal mobilization done before you get there, okay. The patient already has a collar on, they're already on a board, something like that. Okay, things like patient complaining of weakness, or paralysis, or tingling, things like that of their extremities. Okay, deformity of the spine and high risk mechanisms of injury. Now, these are just kind of guidelines when you talk about spinal immobilization and assessment of the neck. I'm just kind of rattling off here. So your guideline might be different where you are, but this is just some of the basics I'm talking about when it comes to trauma and assessment of the neck. Okay, so any of the criteria I mentioned, if they're present, and even a lack of any of these criteria, and you personally have a concern for a potential spinal injury, go ahead and immobilize the patient. Okay, every case is different, every patient's different, your assessment findings might be different. Okay, so just keep in mind, guys, that spinal mobilization, more and more stuff is out there. It's not necessarily this harmless procedure, so try to think about that when you're applying spinal mobilization to patient, and try to limit, that immobilization to patients who meet criteria that we've talked about, or criteria that might be set by your medical director when it comes to spinal mobilization, selective spinal mobilization, depending upon your findings. So that's it, guys, for today's Monday Minutes. Again, just real quick, assessing of the neck from a medical aspect and from a trauma aspect. It's, a limited little area there, but there are some things that you can look at to be able to document appropriately and try to lean towards what might be going on with your patient. Guys, I hope you can use these Monday Minutes. As always, if you've got some minutes of your own, be sure to send them over to me. It's contact@emsofficehours.com. Until next week, as always, Jim Hoffman for EMS Office Hours. Stay safe.